We treated his first rib yesterday, and the mobility of that rib has retained. It's still moving well, and he knows how to self-treat that. And so today I want to test the acromioclavicular joint. So the clavicle starts right by the manubrium above at the upper part of the sternum, and it comes across here, and then where you feel it jump, there's a little bump that it jump, a little jump there, and that is the top of the shoulder blade, which is called the acromion. And so what I'm going to do is capture the shoulder, capture that acromion, and I'm going to distract laterally because I want to gap that acromioclavicular joint and test mobility. So I capture the shoulder, including the humerus, the upper arm bone, and my direction of force is this way. Regardless of the angle you see my arm in, that is the direction of force that I'm imparting. And so I push firmly and I take up the slack. Okay, now my arm angle replicates the direction of force. And then I thrust it. And I feel it spring forward and I feel it bounce backward. Okay? On this side, we tested you already, and we found that we could take up the slack similarly, but then there was no ability to spring it. So now I can't thrust it. Okay? So you seem to have a little bit of a protraction of the scapula, compressing that acromioclavicular joint. And the clavicle does present as being more anterior on this side. Again, we have good mobility of the clavicle. I can spring it posteriorly, I can spring it inferiorly, but it's the acromion that lacks the motion. So for that reason, I think the scapula is protracted. This is going to inhibit your muscle function a little bit. When you have a joint restriction, you also have inhibition of muscle function, and that's mediated by a nerve that goes to the ligaments, called a type 2 mechanoreceptor. And you also have over-lengthening of some muscle. You have shortening of the muscle in the front. And a shortened muscle or a lengthened muscle is not in its normal resting neutral zone. And so muscle function can be inhibited. So I'll have you lie on your stomach and I will see if we can isolate that weakness. I will mobilize that joint and then we will see if we were able to remove inhibition. So I'm going to have you bring your arm up sideways on both sides. And I want you to lift your arms up towards the ceiling. Okay? So your shoulders are flexed at 90 degrees and give me everything you've got. Ready? Go. 1, 2, 3. Powerful. Excellent. Beautiful. Okay. Now I'm going to test your upper trap. So I want you to reach forward with this arm. Okay. And lift up both sides. Ready? Go. 1, 2, 3. What do you think?
My right shoulder popped.
Uh-huh. Uh-huh.
But yeah, it felt weaker too.
Yeah, I thought so. Lift up one more time. Ready? 1, 2, 3, go. Oh yeah, it's so easy to push that right side down.
Yeah.
So we have inhibition of the middle trapezius on the right side. Okay? So go ahead and lie on your back one more time. Oh no, stay there, stay there, stay there. I'm going to show you the self-treatment. I buy this foam from Foam America, like Foam America. And it's a 4-inch diameter round foam. And we buy it in lengths of 72 inches. And they probably sell it in smaller lengths. And what I do is I have the client, put your arms on both sides, and I have the client take this and put it right under the outside of the shoulder. Okay? A lot of people need this on both sides. You need it on the right side, but we'll go ahead and stretch your shoulders on both sides. And so this is the self-treatment that I do. I do a hands-on mobilization to that joint, but this is the way that I have the clients treat it themselves. Because my whole philosophy is make the patient independent instead of having you have to come back and see me repeatedly. That's just not what I do. It's a bad business model, as I've stated earlier, but it's what we do. So we'll do this stretch for 3 minutes, and then we'll come back and refilm the mobility.